go.
No, this is my problem. Okay, today we're going to cover scoliosis correction. Okay, and what we're looking at is how the human body works. First off, scoliosis is absolutely correctable, but how do you tell? First off, what you're doing is, now this is the A to P view, and we're looking at a scoliosis here. Now we're using the Cobb angle to measure it. So how do you tell if this patient, if you can get it corrected or if you can't? Well, first off, what you do is you take this patient and you bend into the convexity of the curve. So if you bend it and it doesn't change, you can't correct it. You bend it and it does change, that's the minimal amount of correction. Minimal, not maximum, minimum. Why? Because what we're doing, we're not changing proprioceptive firings, we're not changing the neurology behind it, we're not restoring the disc, we're just seeing what the limit of the ligaments in the spine will allow. Ligaments, osseous structures, whatever. So it doesn't matter if you have a hemivertebrae or any of that, all scoliosis, that's how you tell if it can be corrected. So what we do is we take this patient, bend her off to the side, and sure enough, she goes from a 21.8 degree curve down to 3.5. So we can actually correct this.
Is she actively doing that?
Yeah, yeah, we just bend her. Okay, so this is her standing up straight, weight-bearing x-ray. All of them are weight-bearing because you need to see what her body's like in situ. And you flex into the convexity, and if that changes, that's the minimal amount of correction. That's your goal. Okay, now, how you get this corrected? Well, first off, let's look at the problem. Why does the body develop a scoliosis? First off, you're supposed to have lateral curves in the spine. You're supposed to have a lordosis, kyphosis, lordosis. What you're going to see, typically, when you're looking at the front, it's supposed to be straight up and down. In scoliosis patients, they're missing a lordosis in the cervical, they're missing the kyphosis here, and they can't walk around like this. There's no shock absorbing. Okay, so they're going to develop the scoliosis. So what you're going to see 100 times out of 100 in somebody with a scoliosis is that they're missing the lateral curves. Let's see if that's true in this patient. Duh. Okay. Sure enough, this is her lateral lumbar. She actually has a reverse disc here. She's got almost a kyphotic curve in the lumbar. Let's look at her cervical. Her cervical, that's absolutely no curve whatsoever. Okay, let's look at her thoracic cage. I mean, this is a really, really slight, minor scoliosis here. But look at the rotational malposition of the spinous processes. My gosh, that's shoved way over to the right-hand side. Now, so when we restore this front to back curve or the lordotic curve in the neck and the lumbar, you're going to start to eliminate the lateral scoliotic curve. But also, we have to go over therapies. Now, the plastic elastic deformation curve. Okay, now what that means is you take any material, if you put it under a given force load, okay, for a given period of time, sometimes it can retain its original shape. That's an elastic deformation, so it just bounces back to what it should be. Now, a plastic deformation means that you put it under a given force load for a certain given a time under appropriate force loads, and it retains the new shape. Okay? So human tissue crosses that plastic elastic deformation curve at 18 minutes. So how long do you think that we're going to give her consistent exercises? About 18 minutes. I know. Here, keep that. It's good for studying. Okay, so now this, what we're going to do, in addition to adjusting, and what you want to do on the adjusting, we're going to go over that in a little bit. You want to distract the joint. Okay, so we're going to decompress it. We're going to flex into the convexity, and then we're going to do a drop in this direction, okay, at the apex of the curve, setting it down. We're also going to increase the lordotic curve of the lumbar and the lordotic curve of the cervical. Okay, does that make sense? It's real, real simple. But then we have to give cross-crawl exercises. Now, we're going to also give her this really technical device, a rolled-up towel, okay, and what she's going to do is she's going to lay on this at the apex of the curve. How long do you think she's going to lay on it? 18 minutes. Yeah, that's it. So, and typically, I mean, this gal's 29, but in a teenager, I say, what's your favorite TV show? Okay, I'm going to write your prescription. You got to watch your favorite TV show. It's got to be at least 20 minutes to a half hour. You're going to be laying on this. Okay, does that make sense? It's just pressure over time. Okay, super, super easy. Then let's look at a couple of cases that you can actually identify with. Now, here's a 67-year-old gal. And here's the right side, here's the left side. It's a 37-degree scoliosis. She's had it for a long time now. Her symptoms, you might also know that the pelvis is extremely inflamed. This SI joint is white, it's hot, it's inflamed. That's because if you lock in the area of the lumbar, the pelvis has to move twice as much. So she's going to have complete pelvic instability. So what we do here is we give her a trochanter support to take pressure off. That reduced her pain level by about 80%. But how do you tell if you can get her healthy? What you do is you bend her into the curve. So sure enough, when we flex her into the convexity, she reduces down to 14 degrees. So here's a 67-year-old woman, and her goal is 14 degrees. Now, right now you can see a major osteophyte here. Okay, you can see, I mean, there's got to be something here going on if you got an osteophyte here, but that's the body trying to stabilize an unstable segment. So how are we going to take care of her? We're going to stabilize the pelvis, we're going to distract the joint, apply pressure at the convexity. Don't even worry about the osteophyte there, because just by applying pressure there, you're going to affect a change. And then how long is she going to have to lay on her side on that rolled up towel? 18 minutes. See, her bones are the same age as the 29-year-old one. What happens is the discs in the bones, they're not, they don't age. They're replaced every year, year and a half. Okay, so it's a very dynamic process. These discs are alive, okay, and most doctors don't really appreciate that. So here, her goal is 14 degrees. This is her in about a year. So she went from 37 degrees down to about 27 degrees, okay? Now, a 10-degree reduction in a year is absolutely appropriate. Since her bones are about a year, year and a half old, to reverse this, okay, to get her up to her ultimate goal, which is around 14 degrees, you're looking at around 5 to 8 years, okay, of consistent care, which is really nice because at 67, in 5 years she's going to be 72. Does she want to be 72 healthier? Yeah, I would. Okay, then you could take a look at another case, and this one's very severe. This is a 24-degree bend, or 24-degree scoliosis, and her standing up. How do you tell her that she can be helped? You take that 24-degree bend, you flex into it, and so we do bend her into it, and it reduces down to 12. Okay, now a year later, the 24-degree bend is now down to 15. Okay, her ultimate goal is 12. So this is progressing really neat. Now, the tough part with this one is you can't put a towel here for her exercise. So we're going to do the same adjustment pattern where we're going to distract this. But what we're going to do, we want to increase the kyphosis, because remember, what happens with scoliotic patients is not only are they missing the lordotic curves, they're also missing the kyphotic curves. So when you restore the biomechanics, or you restore the natural curves, the joints of the spine, the facet joints, are actually going to help you realign that scoliosis. Okay, so we're going to actually adjust her from the front, increasing the curve, and we're also going to tilt her body slightly off to the left-hand side. So when we adjust her, and this is going to be her backwards, my contact is going to be over here, so we're going to increase the curve, and we're also going to be torquing it over. And that's how we get that reduction. Okay, does that make sense? Yes or yes? I know, it does. It's really simple. Then when you look at her lumbar curve, this is her lumbar curve at 59 degrees, almost 60 degrees. Now this is her standing up straight. Okay, so how do you tell if you can help her? flex her into the curve. Okay, you know, and this is really, really simple. So we go in, we flex her into the curve. Her curve reduces from 59 degrees down to 30. So our goal now is about a 50% reduction. Okay. Now, this is her 1 year later from 59 degrees down to 51 degrees. Okay. So she's moving in the right direction. Okay, so that's ideal. On hers, and again, her curve correction is going to take, again, about 5 to 8 years to get the maximum correction. Her symptoms are completely gone, okay? But you can't work on just symptoms because 90% of the nerves that come off of this have no pain fibers. So if you're gauging your care on symptoms, that's absolutely foolish. Absolutely foolish. Now, also, we have to go on proprioception. Now, proprioceptive firings are vital. Now, there's two types of muscles, postural muscles and phasic muscles. You don't have conscious control of the muscles that run down either side of the spine or the postural muscles. They increase in tone under influences from the facet joints. There's joint mechanoreceptors here that increase in tone. Now, what they used to think in the old days is that the muscles on the outside of the curve were weak. Now, I say in the old days, tongue-in-cheek, because ignorant physicians are still trying to stimulate these muscles. But through intramuscular EMG studies, this means you actually stick a needle inside of the muscle, you measure the muscle activity. Okay, through intramuscular EMG activities, we're seeing that these muscles are firing all the time. Why? Because you don't have conscious control over them, and they're increasing in tone because the facet joints themselves are opening up, and that facet joint controls the postural muscle. Okay, so what we want to do, we need to change proprioception, and that's the body's position in space. So in actual fact, this patient here, these muscles are shortened, so we need to lengthen them. These muscles are working all the time, so you don't want to use electricity to change the proprioceptive firings. What I will do in a case like this is I'll do, I have a small machine that passes a frequency or a vibration. It just beats her in there, okay, at about 10 cycles a second. Because ligaments relax at 10 cycles a second. And what's the disc? It's a ligament. What about all the ligaments inside of the spine? The same thing. So we pass a vibration in there on only the concave portion of the scoliosis at 10 cycles a second until you feel a fluctuation in the paravertebrals on the convex portion, and then you can go in, distract the joint, and apply pressure. Okay, does that make sense? Good. Any questions? I know, it's so clear and so easy. Okay, so what we're going to do, we're going to go over adjusting techniques on a patient who has a mild thoracic scoliosis. You. Okay, and what we're going to look at here, and this hopefully Danny can, here we also should cover, hopefully you're not filming her name, but this right here, this is 13 neck surgeries of this patient. So can you still help her? Absolutely. She has one movable bone up here. She also has 7 low back surgeries. And this area here you can't adjust. You're looking at fake disc, you're looking at multiple bolts and screws. But what we can do, we can adjust the pelvis, and you can see this whitening of the joint means that the pelvis may be inflamed. So we can stabilize the pelvis, but this is the area where most of her symptoms were coming from. Even though she had the multiple surgeries, that's her before, that's her after. And you can see that it's realigned considerably. And so what we do with her, you obviously can't adjust where the surgeon did his work, but we can distract this area, and again, we're going to apply pressure in the convex portion. We give her exercises for the paravertebrals to increase the more appropriate firings of those muscles. You don't want to relax the muscle. Since the nervous system controls those muscles, you want it to fire off correctly. Okay, now when we look at the patient we're going to be working on right now,
how do you distract specifically those sections and not the bottom ones? Like using your table?
I'm going to show you that in a second. So how do we distract the individual segments that we want to work with and not distract everything else? You're going to contact it. You're going to actually contact the portion and distract it. And it's not going to do any harm to decompress these areas. What you mainly want to do is do the lateral force in this direction, because that's more important. You distract this entire spine as long as you're not moving beyond the paraphysiologic range of motion into the distraction. And that's have they taught this to you in biomechanics yet? The paraphysiologic range of motion. Okay, good. This is where chiropractors live. This is active range of motion. This is passive range of motion. That's the paraphysiologic. We go slightly beyond that just for a brief moment. That changes the firings of the proprioception firings, and then that changes how the body views its position in space, and then that changes how the tone of the muscles. That also changes the shape of the discs. So this patient here, you can see there's a mild curve in this direction and a pretty significant curve in this direction. What we're going to do here, we're actually going to use this bone here called the scapula. Okay, we're going to use this scapula to apply pressure in this direction. And what we're going to have her do is lift her arm, which pivots the scapula and applies pressure in that direction. And that's going to actually correct it. So she has a right convexity, apex around T8, and a left convexity, apex around T4. So this is a brilliant one. Now, what do we know about the curves? We know that she's going to be missing some of the curve in her neck. So we're also going to help her by increasing the curve in her neck, reducing the forward head carriage, which is a bit over an inch, and that's going to help correct the scoliosis. Okay, so now we're going to go over adjusting procedures using this patient here on how to distract it, how to correct this mild curve in the low back, and how we're going to distract this and do the adjustment procedures. Okay? Good.